Everyone, and welcome to today's webinar session. First off, can we all say hi in the chat just to make sure we can all hear what I'm talking about in the moment? Just hear the sound, let's see me visually. There you go, I can see Phil, I can see Charles, Michael, I can see Ian, one of the speakers, Sandra, Adele. That's fine, perfect. So yeah, just a couple of housekeeping. We're going to have Iain talk next. He's going to pass you on to the next speaker, the speaker after that. And there's going to be 15 minutes at the end for a Q&A from 2 till 2:15. So that's it for me for today's session. I'm now going to pass you over to Iain, and have a good day.
Thank you very much for the introduction, organising the session, and thank you to Massimo for sponsoring this. My name is Iain Goodhart. I'm a consultant in anaesthetics and intensive care, and I'm the clinical director for virtual wards at CUH. I'm going to talk to you shortly about virtual wards, what they mean for the country, about transformation and the real opportunity that they present for restructuring healthcare in the future. I'm going to hand you over to Gemma Czech, who's a matron who was fundamental to setting up the virtual ward at CUH and is now a clinical specialist working for Massimo Technology. And then Andy Bailey is also going to talk to you. He was our operations manager, who again is currently running the virtual ward with me and has huge insights into metrics and data that you need to be considering when you're evaluating the success of your implementation and where you need to focus your efforts. You're very welcome to ask questions in the chat. We may answer those as we go along, but at the end of the session, we'll then have about 15 minutes for questions and answers. So we've had a change of administration from when we were asked to put this presentation together, and that presents us with opportunities. But this isn't a blank check. We have to be able to deliver something real. So when we're told that there's going to be no more money without reform, we need to think about where those reforms are and where the opportunities are. And I firmly believe that virtual wards present us with a real opportunity to restructure the way we deliver healthcare, to look at providing service which is more efficient for the country as a whole, but is also far better for patients. The reason is that virtual wards are that gatekeeper between community services and the inpatient bed. They can smooth that transition from the community in, and they can improve and smooth the discharge process for the patient when they're leaving our hospitals. It is really fundamental to healthcare in the future that we increase the way in which patients can access care in the community, and we improve the way in which we communicate with the services. And I think virtual wards can really be central to that. But to deliver on them, to deliver a proper acute virtual ward, we have to think about what are we doing in our hospitals? What do we mean by a virtual ward? There are many virtual wards around the country who have established themselves very quickly with 300 or 400 patients. But when you lift the bonnet on these, quite often some of them are long-term chronic illness community wards, which have then been technology enabled. There is absolutely value in doing that. There is huge value in improving the way in which we monitor those patients. There's huge value in using technology to collect data, using algorithms to be able to identify patients who are most at risk of deterioration, to identify patients who need interventions and support. Absolutely. But these aren't the sort of virtual wards which are going to have the massive impact on inpatient beds, which our healthcare system needs going forwards. GIRFT are very clear about what a virtual ward is. In CUH, we had our GIRFT review yesterday, and it was fascinating to see how the national teams were focusing on certain elements of care. But a virtual ward should be replacing an acute bed. It's an acute clinical service with staff equipment and technologies that mirror what we can deliver as an inpatient environment. Virtual ward services should be fully responsible for the patient, providing medical, nursing, and allied health support through the multidisciplinary team. We shouldn't be doing part of the care and shifting the rest of the responsibility onto primary care. Virtual wards delivered properly should improve the situation in primary care, and primary care in the UK is struggling at the moment. The GPs are working harder than ever with real challenges. And when we deliver virtual wards, we recognise that we're taking funding from other community services and using them to deliver virtual wards, we have a responsibility to make sure that we are supporting those community services, that we are improving the communication integration of the system. The virtual wards, the acuity of the patients in a virtual ward is different to other community services. These patients should be more acute. They should be so unwell that it warrants that investment in the consultant physician or senior general practitioner input. Virtual wards are not for routine GP-led care. They're not standalone monitoring. They're not for safety netting. Now, this word of safety netting gets misused, in my opinion. Safety netting is a fundamental way in which we manage patients when we discharge by giving them instructions, alerting them as to what they need to do if they become more unwell. So when they use safety netting in this term with Goodhart and NHS England, it's talking about the sort of the gentle reassurance. If you're not feeling better, just give us a call back. Safety netting, I think we need to be clear about that from a clinical perspective. Safety netting is a valuable way in ensuring our patients are kept safe. Virtual wards are not there for standalone OPAT, and this can cause confusion. OPAT, outpatient antibiotic treatment, is historically or traditionally thought of as being for patients who are very, very stable, who are not going to need readmission, but they need antibiotics to be given in intravenous form because of a reason, either because of the agent that they need or because of route of absorption access. A virtual ward can still have patients who are receiving OPAT, but that patient has to be so acute that they would otherwise be needing to be in an inpatient bed. When we think about virtual wards and think about acuity, we've got a huge spectrum of patients. Patients who are potentially stable, who may potentially have been discharged, but the clinician may have been a bit nervous about, who may be wanting to bring back within 24 hours the following day, and the team are discharged because perhaps they feel under pressure. Perhaps they feel they've got to maintain movement in their organisation, but they're not comfortable in themselves. And I think with virtual wards, it does come down to some of this about clinician decision-making. And we can't really mark out new pathways unless we're honest about those processes, honest about those decisions surrounding risk. Because ultimately, all of the work that we do involves risk. We keep patients in hospitals because we want to monitor them, because we want to make sure that if they deteriorate, we have a way in reaching them quickly, we have a way in instigating treatment and potentially escalating their care to somewhere like critical care. So when we're talking about asking our clinicians to send a patient who they would historically have kept in a hospital bed home, we're talking about asking the patient to accept a certain element of risk, and we're asking our clinicians to also accept an element of risk. And so there needs to be an open and frank discussion about the thought processes which go into that. Where do we draw those lines? And those lines may be different for one clinician than they are for another. So how do we support them? How do we achieve uniformity? What devices are there which can enable us to be able to keep that patient safe, even though we can't keep our hands on them, even though we can't see them at the end of the ward? It means turning things upside down. It means really thinking differently about how we deliver healthcare, recognizing there are risks with inpatient stay. There are also risks with going home. Turning things upside down can make people feel really, really uncomfortable. And when you're developing virtual wards, you've got to be able to support your teams through that process. But is it what our patients want? The NHS, and this is an extract from Lord Darcy's recent letter, the NHS is something which is fundamental to the psychology of this country. People believe in it. It's something which we believe we have a right to, and we mustn't undermine that. But increasingly, the NHS has been struggling to deliver for various reasons, and it hasn't really recovered from the COVID effect, which has had implications not only for the waiting list, but also for staff morale, staff retention, and pathways which were changed. But when we look at virtual wards, and we look at the experiences that our patients in virtual wards, we find that this is totally different. We're not seeing low levels of satisfaction. And Andy Bailey will show you later on the feedback which we're getting from our patients in CUH, which is replicated elsewhere across the country with other virtual wards. So I'm talking about virtual wards. We're talking about taking people from an inpatient environment and sending them home. Is this new? At the end of the day, we've been able to send nurses to patients' homes. GPs have been doing home visits. You can give IV medications in patients' homes. We can give oxygen therapy, blood tests, wound care, end-of-life care, dialysis, ventilation, home births. All of these things have been done in the patient's home over the last decades. But actually, what is different with virtual wards? What is it which makes the difference? And the key is our ability to be able to deal with that element of risk, to be able to reassure the clinicians that the patients are safe. If they deteriorate, we're going to know about it. We're going to be able to intervene to support them. To be able to reassure the patients that they're safe. So it's that ability to be able to observe the patient who's at risk of deterioration, to be able to use monitoring, intermittent spot check or continuous monitoring, which I'm a very, very strong advocate of, because with continuous monitoring, you completely transform the way we respond to deterioration. We're no longer reactive, detecting a high news score on the ward, potentially 3 or 4 hours after the organ damage has happened or after the deterioration started. Instead, we're seeing trends and we are proactively intervening before end organ damage occurs. This allows us an opportunity to think really differently. It allows us to look at emergency care pathways, but also elective care. The graph on the screen at the moment takes one surgical procedure. Now, this is ileostomy reversal. So patients who have had stomas and they don't want that, cosmetically it's not acceptable, or from quality of life and function, and they have a real impact on some people. And so reversal of this stoma is really important for some patients, and it's an operation we must offer. But our patients have this procedure and then they stay in hospital. So the red line on this graph is the percentage of patients who were still on an oxygen delivery device. And the blue line is the number of patients who are in hospital. And so you can see the gap on the x-axis, you've got numbers, and that's the number of days. So even at 4 days, we've got about 70% of patients in the hospital, but only 5% were needing to have oxygen. So these patients didn't need to be in. At the time of doing this, we weren't able to provide oxygen in the community. That's now changing this month. So all of these patients were being kept in the hospital, away from their families, exposed to the risks of inpatient stay, but without actually needing to. So we changed that pathway. We gave them continuous monitoring, and they went home. They now go home at 24 hours. So we've been able to fundamentally change the bed occupancy in that unit, be able to do more cases, but also improve the service of the patients. It's really, really important to remember with all these virtual wards is we're not throwing the patient out and abandoning them. There is still personal contact. We've been really, really strict at CUH to maintain 24/7 cover. If a patient is on my ward at 2 o'clock in the morning as an inpatient, if they've got pain, if they're unhappy, if they're worried, they expect to be able to ring the call buzzer and speak to the nurse. Our patients in our virtual ward can do exactly the same, but they've got the added benefit that when they speak to that nurse, the nurse can see continuous data. It's not a case of having to then do some observations and then speak to the doctor, look at the trends, look at the changes. They've got that data live in front of them. Personal contact is really, really important, and that's why we get such high satisfaction, because our patients who go home on the virtual ward can pick up the phone straight through to one of the nurses directly. They don't have to go through the hospital switchboard, press 1, press 2. They don't have to press the call buzzer. They get straight through to one of our nurses in the virtual ward. That nurse who will know about them, they will have received a handover from them and have access to their full medical notes. In order for virtual wards to have an impact, we need to be able to have lots of different aspects, lots of different routes of access. We need to be able to have admission avoidance with direct referrals from the community. We need to be able to have step down from the acute beds. We need to start to embed virtual ward care as part of standard care. So patients with aortic dissection, for example, will historically stay in hospital for about 4 weeks. For much of that time, all that we've been doing is checking their blood pressure once a day. We've been there to safety net in case they develop new symptoms. But we've exposed that patient to over 2 weeks worth of risk of inpatient stay. They're perfectly mobile. They're perfectly able to care for themselves. They don't need to be risking burdening family members. But they are stuck in hospital. By using virtual ward, by using continuous data, by using Bluetooth linked blood pressure devices, we're able to get their live data sent through to us. They can get hold of us just as quickly as they would if they're on the ward. So now virtual ward is part of their standard care. They go home 2 weeks earlier. This transforms their experience of healthcare and transforms the demands on our hospital. And some people worry about the impact this has on carers. And it's really important that virtual wards should not be imposing a model of care on patients or families or carers who are unable to cope. It's very important that actually we choose the right patients in the right environments. What we find from some of our relatives is that they, and families, and we do focus groups with all of our patients, is that actually the opportunity to be at home, to be free from those daily trips to the hospital, enable them to be able to recover better, enable them to be free from many of the stresses of that interaction, that separation creates. It's important that you've got processes in place to support carers, to support other professionals who may be involved in managing that patient. But remember, the virtual ward patient should be the exclusive responsibility of the virtual ward. So we shouldn't be imposing additional burdens on other services because they are our responsibility on our virtual ward. So I've given you a bit of an overview as to why I think they're so important, why I think there's a real opportunity with virtual wards to remodel delivery of healthcare for the benefit of the country, but also, and most importantly, for the benefit of our patients and their families. I'm going to hand you over to Gemma, who's going to talk to you in more detail about the journey of the virtual ward and about the capabilities. Thank you.
Thank you, Ian. Thank you. So I'm going to talk to you about the journey so far and how we got to where we are now. So the virtual ward has been implemented to support flow and capacity across Cambridge University Hospital. The virtual ward offers an alternative place to receive hospital level care. The priority for us was to identify patients who can be managed at home using non-invasive monitoring that is FDA approved and can enable patients to receive ward level care in the place they call home. We like to look at patients holistically, and that is a priority for us as every patient has different needs. We create personalised care plans for our patients to ensure that patients are treated as equals and receive the care that they expect to ensure they're managed safely when discharged home. Virtual beds are important that we use technology and the holistic approach, and they can also show and demonstrate ways in how we can be sustainable for the future. So the reasons that our patients like the virtual care is that it reduces deconditioning. We all know that as soon as you're admitted to hospital, there is a risk that you are going to reduce decondition in mobility, nutrition, and well-being and mental health. We have proven that it improves recovery, and we have data that can show that. We also have our patients go home, and it's a familiar environment. They have 24-hour access to a nursing team. They can sleep in their own bed, eat the food that they choose, have that time with the loved ones, participate in normal and daily activities and hobbies. There is the option to work depending on why they've been admitted to the virtual ward. They can go outside, and most importantly, it improves well-being for our patients. All of this is demonstrated in our feedback that we have, and we are proud to say that all of our patients that go home, they have given us positive outcomes and have had positive experiences on the virtual ward. Promising to offer a patient ward level care in their own environment is a new concept of providing health and delivering that. And we have demonstrated that, and we're very proud of that at Cambridge University Hospital. So as you can see from this slide here, what we can actually offer our patients is all of what we would expect to offer on a ward. So we're not saying that every single patient doesn't need to be in a hospital bed, but there are lots of patients that could potentially be managed at home. So by offering our continuous and intermittent vitals monitoring, we're able to monitor our patients to recognise for any changes or deterioration of our patients. We also can offer things like blood tests and imaging slots. And actually a lot of patients are just waiting in hospital because they're waiting for a CT or they're waiting for their bloods to improve. And there are services in the community using satellite units so patients don't have to come back into hospital for these tests. Or offering things such as home visits to do the blood tests, and also they can come back into hospital as well. But actually for us, it's about why should the patient stay in hospital if we can offer that in their own home. We also offer things such as wound care, pain assessments, the food and fluid charts and your stool charts and your fluid output charts, all things that we know as nurses that we're doing every day for patients in hospital, but actually we have demonstrated and proven that you can do it remotely on some of these patients. We assess these patients and provide care plans to these patients and call them up to 4 times a day to check on their symptoms and well-being, but they also have 24-hour access to a nursing team. They can call us up and they can ask questions. They can tell us that they're in pain and we can help them. They can tell us that things have changed, and also most of the time we can be able to talk to the patients on the phone and make a decision without them having to return to hospital. We can also provide IV therapies, which we invite our patients back into our clinic area for those at the moment. We also offer home visits to some patients that can't come into the hospital. We review results and liaise with the parent teams of the patients and our virtual ward doctor every day. We do medication reviews and work closely with our virtual ward pharmacist and more. So I suppose from this slide, it's about asking everyone to think for what would you be doing in a hospital bed, and could you actually have that at home? So when setting up our virtual ward, we know that in order to be successful, you have to have a key relationship with your stakeholders. These play a large part in the success of your service, and this group of people are going to be people that are going to make decisions about your service and also be the promoters of your service as well, and help you to develop a successful project. So looking here, just talking a little bit about our stakeholders and how we achieve this. So we invited our stakeholders to a core planning group once a month, where we would have the opportunity to talk about everything that was going on in the setup of our virtual ward. And we've actually continued to do that now as our virtual ward continues to develop, as there is still so much to learn and so much to do and so much potential for virtual care. So just to give you a bit of insight in my advice on what I would do if you're thinking about setting up a virtual ward, is that you need to make sure that you have a good partnership with your technology providers. So your e-hospital, your video monitoring, your phone systems, your wearable devices. Having access to a transformation team helps support the integration of the service and continue to support you in your service transformation. Linking in with members of the public, holding focus groups with previous patients for ideas and opinions to help you create your patient information leaflets, but also asking previous virtual ward patients to come to a feedback group so that you can learn to continue to develop your service. Having those relationships with your professional bodies and partner organisations, including everyone, because they will all be involved in making the decisions for these patients and how your virtual hospital continues. Making sure that you have a good working relationship with HR and recruitment, because they will assist you with your advertising and your employment checks. And it's really important that you have a strong, robust team on your virtual ward. And then linking in with your community and volunteer services, and then making sure that you create these strong working relationships, because they will be able to support you in looking after your patients in the community. And it also ensures that you have a smooth transition of communication, particularly with people such as your GPs. On our virtual ward, we reached out to volunteer providers to ask if they could help with courier services, such as taking medications to patients' homes, collecting equipment, and also you could even look into seeing if they can help with some transportation for your patients and to come back into hospital. So the next thing I just wanted to talk to you about is about the priorities of setting up your virtual ward to ensure that you have success when setting up the virtual ward. So I'm just going to click onto another screen, apologies. So it's really important that you have a good, strong business plan. So you need to outline your goals and your strategies to achieve your outcome. Work with your project managers to ensure that you're thinking about the methods and the processes, the skills that you need for success, and how you're going to work as a team, and making sure that you can work within your time frame. And then funding. So ensure that you have funding to set up your service. Be realistic. From my experience, it is cheaper to have a virtual ward bed, but actually safety is the priority for your patients. And virtual wards are not there to cut corners. They're there to be developed for better outcomes for your patient as a whole. For a staffing model, so include all the staff required. So thinking about your pharmacists, your doctors, your nurses, and start that recruitment process as soon as possible, as you can't do this virtual ward, setting up a virtual ward on your own. So from my experience, a nurse to patient ratio, which I did based on a time in motion study, worked out to be about 1 to 15 in the day. And it would worked out to be about 1 nurse to 45 patients overnight. Obviously, your service may be slightly different. But from the time and motion study that we did, based on the time it took for us to do an assessment of the patient and any interventions, it came out as a 1 nurse to 15 patient ratio. And then your patient engagement. So as I talked about before, making sure you have those patient focus groups, making sure you have your patient feedback leaflet information, so that you can actually ensure that the service you're delivering is meeting the needs expected by your patients and the clinicians. And then your resources, ensure that you have the correct resources, make sure you have the correct equipment, the space to work from, any transport and any technology. Work with your procurement teams, work with your medical device services, your e-hospitals, your operational team, and everyone else that will be able to be beneficial to you to create a successful, safe virtual ward. So the communication and publicity. So start talking about your service, shout it from the rooftops and tell everybody what you're doing. Share those success stories, hand out leaflets, create QR codes for people to access your information leaflets, and work with your comms teams and talk to your doctors and talk to the patients and talk to your nurses, as all of these will be people that will want to see a success on the virtual ward. And then regarding clinical governance, hold those monthly meetings so that you are with your stakeholders and be transparent about your service. Demonstrate that you're being accountable to continuously improve the quality of your service and provide high standards of care. When it comes to doing the inclusion and exclusion criteria, make sure that you're clear with who can use your service and who would not benefit from your service. At Adam Brooks, we were inclusive of most people, but what this does do by having an inclusion and exclusion criteria is it actually helps the process of the referral from the clinician much more slick, because then they will know whether or not that patient is going to be suitable for the virtual ward. When looking after your patients, make sure you've created care plans that they're going to be able to, that you're going to be able to meet. Don't promise expectations that you're not going to meet to be able to have the patients on the virtual ward. Be realistic and create that care plan with your patient. Make sure it's personalised. Make sure that you've met with that patient and you have an understanding of their expectation and their needs. And then use those education packs that are available, and also make your own education packs as well. So on our virtual ward, we have over 30 specialties. So you can imagine that that's actually a lot of different medical needs and surgical needs. And so these nurses are going to need to have know a little bit about everything. And so it's really important that you keep them up to speed of what's going on, any new information, link them in with the clinical specialist nurses, as I really truly believe having good education on a ward is what helps with staff retention. And make sure that you also have education packs available for your patients as well, especially when it comes to wearing the wearable technology. And most importantly, just continue to be enthusiastic about your service. Setting up a virtual ward and getting the buy-in from everybody, it's not everyone's going to agree with virtual care, especially doctors that already work in the main hospitals as well, as they're used to seeing their patient at the end of the bed, and suddenly managing them remotely isn't something that they're used to doing. But actually more and more people now are being managed remotely, from clinic appointments to doing a lot of admission avoidance work. So keep being enthusiastic and create that enthusiastic team so that everybody knows what a virtual ward is and everybody wants to be on your virtual ward rather than be in hospital. So talking now about the technology on the ward. So sorry, I'm just going to go on to another screen here. So the technology developed for patient care can alleviate the burden to hospitals and improve the patient care and outcomes. To allow the use of technology to be safe for the patients and provide confidence in the clinician, you must buy it right. So you have to look at what equipment is going to be right for you, what is the purpose of it, and how much do you need to rely on the vitals monitoring. You also need to use it right. So make sure that you understand how the technology works, because you'll be the one that is teaching your patients how to use that. Make sure that it is user friendly and make sure that everybody understands its function and operation. And then keep it right. Make sure there's someone dedicated to looking after that equipment, making sure there's someone that's going to clean that equipment. They're going to collect that equipment from the patient's home, making sure that they're having it serviced, making sure that the batteries are changed, all simple things. But actually, when you don't look after your equipment properly, straight away, it's going to become a cost implication. So for us at Addenbrooke's Hospital, we chose to go with Massimo. They have an existing partnership already within our trust where they provide technology to theatres and critical care. So from my experience, we knew that we could rely on data that came from the sensors we were going to use. We needed to ensure that our technology would be safe and effective when caring for patients who should be in a hospital bed. We chose to use Massimo signal extraction technology, which is clinically proven and FDA approved pulse oximeter. It measures our data accurately through motion and low perfusion, which provides us with confidence that the device would be reliable and ensure patient safety. It enables us to recognise any changes or deterioration for our patient. To be able to create a news score for our patients, we use temperature and BP monitoring in addition to the pulse oximeter. So just to demonstrate what our equipment looks like. So here we have a pulse oximeter. We offer continuous and intermittent technology. So on the hand, you can see this patient here has a intermittent SpO2 and heart rate monitor. And then we have our blood pressure monitor as well. And then we also have here on the patient itself in the bed, this here would be monitoring our temperature. So this is 24-hour monitoring of the temperature. And then where she's wearing on her hand is a wearable device, which is comfortable for the patient. And that monitors their SpO2, heart rate and respiratory rate 24 hours a day. So in our nursing hub on the ward, that data is transferred to us using Bluetooth-enabled technology. The patient, when we meet the patient, we download an app onto their mobile device, and then that is then Bluetooth connected, and then that technology comes through into the nursing hub so we can monitor the patients. So as you can see here, this is one patient who would be on continuous monitoring, and that enables us to see if there's any changes or if there's any concerns, and then we can escalate and decide what we need to do with that patient. So the daily management of the ward. So one thing that we did on our ward at Addenbrooke's Hospital is we wanted it to mirror what a physical ward would be within the hospital. So on the daily management of it, a nurse in charge would be allocated and they would have handover of the patients to the nursing team from the night staff. They would then review any new referrals for the day and plan who was going to go and visit those patients on the ward. The patients we have on the virtual ward at the time will always be our priority as they are in our care. We then have the personalised phone calls and video consults with our patients on the virtual ward. Some patients will attend our day unit, or some will have home visits for treatments as well. So we monitor the Massimo dashboard and respond to the vitals as required. We have a ward round with the nurse in charge, the doctors and the pharmacist daily. And we always host huddles with our nursing staff to share relevant information. It also gives an opportunity for us to discuss any concerns about our patients, any patients we haven't been able to get in touch with, and any planned activity such as delivering new medications to the patient. It helps us to ensure that we're providing safe, effective care to our patients, and we're making sure that everything that is expected has been done. The medications are reviewed and couriered to the patients as required. And then we onboard the new patients to the service. So as you can see, looking after patients on a virtual ward is very similar to looking after patients on a physical ward, but the only difference is that you're doing it remotely, seeing some of your patients, but primarily the goal is to make sure that you're keeping these patients at home, but they're managed safely and effectively. And so what I just wanted to talk about for the last part of the presentation here is just about the onboarding process. So when we go and onboard a patient on the ward, that patient would have been told by the doctor that they're considering referring our patient to the virtual ward. They will then do an order to us, and we will then go and visit that patient after reviewing their notes. So the nurse in charge will review the referral, visit the patient on the ward, do an introduction about the virtual ward and gain consent from the patient. We then create the personalised care plan that I've been talking about earlier with the patient, and then we contact the family or the carers as needed. We explain about the technology and we choose what technology they need. Are they going to need intermittent or continuous monitoring? and then we provide the education as required. We make a plan for any investigations made with the patient, for example, the imaging or the blood tests, or if they need to come into hospital, or if we're doing home visits. We arrange how many times a day we're going to be calling that patient, and they also know that they can call us 24 hours a day and they don't need to wait for a nursing call. We then read through all of the notes to make sure that everything that needed to be done, the discharge summary, the medications have been ordered, they've passed the physio assessment, for example, to ensure that they're safely have their care redirected to virtual care. We make sure we communicate with all the staff on the ward and the founders and the carers so they know what the next plan is and that the patient has been accepted onto the virtual ward. What we then offer is we call the patients in the evening to make sure that they are aware of their transfer to the virtual ward, that they understand everything that we've said to them, because sometimes it can be a lot of information given at that bedside. When you're not feeling well, then it's harder to retain that information. And then they also know then that they can call us at any time, 24 hours a day from that moment they're in their own home. Thank you. I'll hand you over to Andy now.
Thanks, Gemma. Hi there. My name's Andy Bailey. I am the Virtual Ward Operations Manager at Cambridge University Hospitals. I'm just going to be talking to you a little bit about the challenges we faced as we set up the virtual ward, or the biggest challenge that we faced. Some of the data that we collect and how we measure the impact and the outcomes of the virtual ward, a little bit about the patient experience on the feedback that we've had, and then a summary of where we're at now and what our next steps are going to be over the next sort of 18 months to 2 years. So just to give you a bit of a flavour of what Cambridge University Hospital is like, we're a big acute hospital, roughly about 900 to 950 beds. We have roughly about 50 to 55 ITU stroke neurocritical care beds. We have a big emergency department with a major trauma centre that sees roughly about 450 patients a day. So we're a big acute hospital. But on the side of that, what we also have is we're a tertiary centre. So we see patients, our scope of patients outside of Cambridge is quite big. We see a lot of patients outside of the region. Cambridge University Hospital serves Cambridge, which has a population of about 150,000 people, but it also serves a lot of Cambridgeshire, which has a bigger population of about 650,000 people. So there's a lot going on at Cambridge University Hospitals. Our biggest challenge, without doubt, when we started setting up the virtual ward was really about getting buy-in from the clinicians, from the specialist nurses, getting everyone bought into this new idea of care. When we scoped it out and we spoke with staff, we had a really big 50-50 split in the camp. We had a lot of clinicians and stakeholders this is the best thing for the NHS. This is going to save lots of money. This is great for patient care. This is the future. This is what we want to be delivering. But on the flip side of that, we had many people that were a bit more skeptical of, I'm not sure how this is going to work. I don't think this is going to be safe. Is this a direction that we want to be going down? So we had a big divide in the camp. And when we were given the finances to be able to set this up, we were given a target and some budget to enable us to deliver what we called a 45-bedded model, so that a capacity was going to be at 45 beds. So we launched on the 1st of November 2022, and we got our first patient. They came from ITU, so that really showed the ambition of the virtual ward and how we wanted to press. We weren't looking to be a safety netting service. We wanted to treat sick patients. Sorry, I've skipped on a slide there. We didn't want to be the safety netting service. We wanted to demonstrate to the rest of the hospital we were looking after sick patients and delivering this new model of care. So that first 4 months we were running, but we were getting 5-10 referrals maximum a week. Our occupancy was about 5 or 10 patients whilst on the virtual ward for the first 4 months. It was absolutely not the big boom that we were hoping for. People weren't jumping on this. But what was really, really good to see, and what was coming back to us in abundance of, was those patients that were coming onto the virtual ward was all around their patient experience. And the stories that we were creating from that patient experience was just amazing. So, so for the people that did buy into this new model of care, those people that were really looking for the future, we gave that information back to them, those people that referred, and we told them the story of what happened to the patient after they referred to us, and we did that over and over again. And what you can see here on this slide, hopefully, that the team, is actually the amount of communication we did across the trust in order to get that clinician buy-in. We literally, every single forum we could be in, we were shouting about the virtual ward. Every single person that would listen, we were shouting in the local press, we were shouting in the national press. Every opportunity there was to celebrate success, we were getting that message out. And then all of those patient stories that we were getting back from our patients, we were able to share with the teams. And that created an exponential effect, really, for us, because you'll see when I show you the stats in a minute, that actually as we moved closer to the summer and we started sharing that feedback, that our numbers climbed, and we hit 45 bedded occupancy very, very soon by I think it was June. And then by September, we'd almost doubled the occupancy. We were up to 85 patients. So the impact of sharing them patient stories and that patient experience really, really did overcome that problem. And actually now when we talk to specialties across the service, they're looking at their next opportunity, their next pathway that they can set up with us in order to deliver virtual care for their patients. So this is our team, and these are some of the communications that we put out there. So as part of sharing that communication, what we did on the side is also we created what we called an impact dashboard. So we wanted to demonstrate to the hospital that we were going to make an impact on the hospital in these various different ways. Now, on the top left-hand side there, you can see our occupancy grid, and you can see what I was talking about, where actually when we hit to June, we started getting that patient experience data back, and then the exponential effects that actually by September, we would double what our trajectory was, and double actually what our budget afforded for. So we were asking for more money, which was another story. But we've managed to sustain that over a long period of time now, but you'll see a small taper off there, which I'm going to discuss in a minute about length of stay. But it's been a really, really big success for Cambridge University Hospitals. I've worked there for now 10 years, and every year when it gets to winter time, we open a winter ward to help create additional capacity. This last winter that's just gone, was the first year we didn't do that. Now, I can't say that was all down to the virtual ward, but I'm absolutely certain that we had an impact on that. The second chart here in the middle is our acuity. Now, one of the ways that we try to demonstrate that we're not the safety netting service, that actually we're looking after sick patients, is we capture the news scores of all the patients coming onto the virtual ward, and we compare them to some of our short stay medical wards. And what you can see here is the blue bar is the virtual ward, the orange and the grey bars are two of our short stay wards. So you can see the acuity spread is not dissimilar to two of our short stay medical wards. So it's just another example where we're showing actually, we're looking after patients that actually would be in a hospital bed. This graph on the right here is our bed saving days. I'm going to talk a little bit more about that, about how we calculate that in the next slide. And the patient experience, I'm going to talk about that in a minute as well. I referred to the tapering off of our occupancy, and there's a reason that's happened, and a lot of it is to do with length of stay. So since the beginning, really, we've been sitting at about a 10-day on average length of stay for our patients. We have had patients that have stayed longer than that, but in general, it's about 10 days. Now, what we've done over the last couple of months, over the summer period, is we've employed an additional junior doctor, and we've implemented CFDs, and we've been really clear with the clinicians that are referring into us of what does a good discharge look like? Well, how long do you expect them to stay on the virtual ward? And that has enabled us to quite significantly start reducing the length of stay. And that's the consequence of doing that has meant our occupancy has dropped a little bit. But what that's enabled us to do is have further conversations about all these additional pathways that we can take on. So we've changed the efficiency of the virtual ward. I mean, this is something that's only been running 18 months, but it's learning for us and it's learning for the hospital all the way through. Now, this middle chart here, you'll see, is our referral to admission time to the virtual ward. Now, there's a big push at the moment at Cambridge University Hospitals into improving morning discharges. So in order to alleviate some of the capacity issues across the trust, across the emergency department, we're aiming to get patients out of the hospital as soon as possible. And the virtual ward wants to be part of that. So we now measure ourselves on actually from the point of referral, how quickly can we get a patient out of the hospital and into the virtual ward? So currently we're sitting at about 5 hours, and that time generally ranges from about 4 hours, 45 minutes to 5 hours and 5 hours 15. In the background, we're doing lots of work again to see how efficient we can make ourselves in order to try and bring that figure down. Some of that is out of our control, obviously, things like transport and etc. We can't really impact, but the bits that are within our control, we are trying to impact. On the right-hand side here, you'll see our readmission rate. Now, that's our readmission rate from the point of discharge from the virtual ward. So 30 days after being discharged from the virtual ward, what percentage of patients are being readmitted into the hospital? And currently, we're sitting at about 6 to 8%, which that is on average against a hospital readmission rate of about 12%. So we're halfway. We're just under what the actual hospital is, and that's something we're keeping an eye on regularly. We also look at readmission rates of while you're on the hospital, while you're on the virtual ward, and also we're looking at percentage of those patients that come in back via the ED. Now, both myself and Gemma have both come from working in the emergency department, so we know the pressures that emergency departments are under at the moment, and we're doing whatever we can to try and avoid patients who are on the virtual ward coming in back in via the ED. So we sit at about 1 to 1.5% of our readmissions are coming back in via ED. And the main reason that is happening is because it's out of hours and we can't bring them back in a controlled way, or they need some form of emergency care. On the bottom set of graphs, now what Gemma touched on is we get, when NHS England set out what a virtual ward structure should look like, it was very much aimed at heart failure, respiratory and frailty. When we set out, we wanted to do all of those pathways, but actually we wanted to make it available to all specialties across the hospital. And as Gemma mentioned, we've had 30 specialties now engage with us and are now able to deliver some form of virtual care. The hospital is split in 5 divisions. In Division A is very much orthopedics, surgical services, and ITU. So we get a lot of referrals from orthopedics, a lot of referrals from our surgical assessment units. Division B is a much smaller division. It's mainly oncology, hematology, and urology. Now, we get less referrals from those services, but actually the referrals that we do get, those patients that do come on the virtual ward, their length of stay is actually much more significant on those beds, because they're staying for such longer periods of time. Actually, by virtual ward enabling them to come out of those beds, that we're saving them a lot of bed days. Division C is made up of the ED, our medical assessment units, some of the areas like nephrology, transplant. those sort of areas, infectious diseases, and the big one, frailty, DME, is our leading user of the virtual ward by 3 times compared to any other service. So we've got big frailty DME cohort of patients on the virtual ward. And then finally, Division D, cardiology, gastro, ENT, vascular services. So we have a general spread of those services, but a lot of them are approaching us at the moment about building bigger pathways onto the virtual ward. So that's our dashboard, and that gets shared with our exec team, our core planning team, and anyone else that really gets involved in virtual ward data on a monthly basis. So I mentioned about bed days just earlier, and lots of hospitals across the country are recording this in all sorts of different variations. But the way we're doing it is we're looking at ICD codes. So we measure the ICD codes, or the diagnosis codes of patients that have been on the virtual ward within a 5-year age band, and we compare them to patients that actually didn't come onto the virtual ward. So we've got a direct comparison where we can subtract the two and work out roughly how many bed days that we have saved. So on average, we're calculating 600 to 700 bed days we're saving on a monthly basis. And that's with us being a sort of an occupancy of about 70 patients on average. There are so many opportunity costs as well with this, and that has helped us develop our business case further. Obviously, if we're taking patients out of surgical beds, orthopedic beds, that creates a lot more capacity to deliver that surgery. So there's an elective procedure cost attached to that we can highlight to the trust that we're making an impact on creating income for the trust as well. We're not just about saving beds. So possibly the best part of this job is really about hearing the patient experience data. So on a monthly basis, as I'm sure most virtual wards are really starting to see, is 96% patient satisfaction scores, which is on average the same every single month. And this is a word cloud made of some of what our patients have fed back to us. We do a monthly patient experience survey with everyone that comes onto the virtual ward that month. We run focus groups, and we've also got we're working alongside Sheffield University in the background, delivering a patient experience and staff experience research paper. So, but this is the best part, is I can't think of any other service across a hospital that has patient experience data quite like that. And given prior to this role, I was in the emergency department, I would have between 8 to 10 complaints every single month. Since working on the virtual ward for the last 18 months, I've not had one single complaint. So that in itself speaks of the level of the quality of care and the experience that our patients are having. And we've had some really good news stories from this, where we've got patients home for wedding anniversaries, a lady that recently just had a baby that had to come into hospital that we managed to get out using the virtual ward, a patient who was in ITU that we really wanted to get home for their daughter's wedding, really wanted to go seeing them. And actually, by using the remote digital monitoring technology, we were able to, manage that patient while they're out in the community. And actually, there was improvements with that patient, and they stayed on the virtual ward from that point onwards. But then we've had other stories where we've had patients that actually have been on the virtual ward, and because of the tech that we're using, because of the way we're monitoring them, that actually we've recognized that they've been coming sick almost before the patient has, where we've almost interacted with the patient and said, we've recognized that your temperature is spiking, are you okay? And it ended up enabling them to come back into hospital and having to go to have emergency care as a result of this. So really, really good news story around the feedback that we're getting from patients. I've seen in the chat, there's been a lot of questions around using tech and patients' feedback. So it was something that I was a little bit skeptical of when we first started this. I've got a 77-year-old father who tells me he knows everything, or he demonstrates he knows everything. And trying to teach him how to use a mobile phone, it can often be challenging. But actually, the feedback you can see in the chart below is the ease of use of remote monitoring technology is always good. We relatively never get any concerns or complaints around the use of the technology. And when we do, we are able to log on, we have a video chat with the patient at the time to see if there's anything corrected. We spend a lot of time talking to carers, families, around any issues that come up, and making sure they're fully prepared for when they go back into their own homes. So in summary, where we have got to, on the right-hand side there, you'll see a chart, which is our number of admissions over time. And as you can see, it's grown and grown and grown, which is reflected in our occupancy. We've seen now just over 2,500 patients. We've built this fully functioning ward using remote digital technology. We've got a board round that happens daily with nursing, pharmacy and medical cover. We've developed pathways with over 30 different specialties across the trust, and we feel like we've built that trust now with clinicians. And this is still a journey for us as well, and we're still continuing to do that on a daily basis. We've increased our occupancy over time, despite not really having a clear funding position. We've managed to continually build this service, not having fully agreed what the service costs will be. We've integrated with our IT team, Epic and Massimo. So the Massimo Vitals now feed straight into our EPR. And we recently just won the HSJ award for improving out of hospital care through digital, which is something we're all really, really proud of within our team. So where do we want to go to? Well, the big thing for us, our next step, which I'm absolutely certain we're going to get this over the line before the end of the year, is really about building the step up care. So we're working with nursing care homes and primary care and the community team, social care, in how can we prevent admissions coming in directly into our emergency department? Can we intervene further? So we're developing pathways to set that up. We've got a children's virtual ward that actually, it says October 2024, but actually it's due to launch in the next couple of weeks. We are collaborating. So next to Cambridge University Hospital is the Royal Papworth, which is a heart and lung specialist hospital. They had a trial trying to bring in a virtual ward. Then after a period of time, we formed an agreement and a collaboration with them. So from October 2024, their patients will be coming onto our virtual ward. So we have a virtual ward now that will serve 2 hospitals. And then the final bit for us really is around the expansion of our virtual ward. So we have a capacity roughly about 70 to 80 patients. We want to grow that further by creating further step down pathways and then starting that step up pathway work around admission avoidance. And that's it. We've got a short video to play. It's only 2 minutes long. It'll just give you a bit of an understanding of how our ward works. Is that okay, Liam?
So people use this barcode on the screen and their own mobile devices, that will then take you to the YouTube link of that video.
The CUH virtual The CUH virtual ward at home allows patients to get hospital-level care at home safely and in familiar surroundings, helping speed up their recovery while freeing up hospital beds for patients that need them most. Just as in hospital, patients on a CUH virtual ward at home are cared for by a multidisciplinary team who can provide a range of tests and treatments. If a doctor thinks that you're well enough to be managed at home, they can refer you to the CUH virtual ward at home. They do this by contacting the virtual ward team to discuss your treatment plan. The virtual ward nursing team will do the final checks and discuss with you what will happen. This may involve being remotely monitored and have regular contact with the virtual ward nursing team. The virtual ward nursing team may come to your home depending on your circumstances, or we arrange for you to come to hospital. We will then give you your virtual ward equipment and show you how to set it up. Once you're set up, the virtual ward team will be able to monitor your heart rate, oxygen levels, respiratory rate, blood pressure and skin temperature while you're at home. Whilst you are on the CUH virtual ward at home, we will monitor you regularly, and every day a ward round will happen in the same way it happens on a physical ward. This is where we review your plan, treatments and medications. We will also review to see whether you're suitable to be discharged or need a little bit more time to be monitored or recover. If there is a problem whilst you're on the virtual ward with your health, we may arrange for you to come in, and in an emergency we can call an ambulance. Once you're discharged, a summary of your CUH virtual ward care will be sent to your GP. This will update your GP of your care whilst on the CUH virtual ward at home. Once you're discharged, the virtual ward nursing team will then be in touch with you to arrange a collection of any equipment we have loaned to you, or a suitable time for you to bring it back to the hospital. It's important that we get this back so we can prepare it for our next patient on the CUH virtual ward at home.
Great, thank you, Andy, and thank you, Gemma. I think we had a number of questions in the chat. Some of them I've answered as we've gone through, or answered in part, in order to sort of make sure that the conversation didn't spiral in the wrong direction as a consequence of some of the questions that were posed. Otherwise,
Yes, so what I'll do now, sorry, just to butt in. So first of all, I've posted some handouts, so some virtual ward cost benefits PDF, and the Cambridge University Hospital Virtual Board implementation model PDF as well, which is available for you all to download, as well as a link to CPD points for anybody who's looking for CPD points from this webinar. Also, just to pose to you guys, slides, would you want the slides to be available now for people to download, or that's up to your discretion? Because I can make that available. That's fine. But I've now just made the slides available as well, so people can now download them. So what I'll do now, I'll just go through the questions. I'll pose it to the three speakers in question, and they can answer it. So I'm just going to go for the ones that from the start of this session. So the first one we had from Patricia. She wanted to say, are you having any capacity issues at the moment?
I can come in for this if you like. So we absolutely were from about June, July, we were sitting at roughly about 80 patients, but what we have done is, I mentioned earlier about the work around length of stay, is as we've grown, we've managed to bring in a new junior doctor to work with the team as well, and that consequently has created faster discharge times. So we've reduced our length of stay, which has, as a result, improved our occupancy. So we've now got, we're now not at our total numbers, but not far off it. I think what will be interesting to see as we get closer to winter and the hospital is under a bit more pressure, that actually we'll get back up to that time, and then we'll get up to that capacity again, and then we'll see what happens from there.
We found there were a number of teams who were very keen to embed virtual ward as part of their care pathways, and we were having to turn them away because we didn't have the capacity back in the summer to go down that route. But as Andy says, now that we've improved the efficiency, increased the rate at which we can discharge the patients, we're now opening up those conversations again, and we're expecting that we will rapidly reach our sort of maximum capacity again, and then go back to the trust to ask for further investment to enable us to provide more beds to meet the demand as we come into the winter.
That's fine. And then we've got another question here from Leslie. It says, could I communicate with your re-peered virtual wards and neonatal patients?
Sorry, I missed that. But in terms of the paediatric virtual ward, I think that's a question there. So there are already services in place in an ambulatory setting for things like oxygen weaning with the paediatric patients, but they're limited in scope of what they can do with acute patients and sort of more new diagnoses. So from the 31st of September, the paediatric virtual ward should be going live. The delay is just waiting for their EPIC build to be finalised. They're then going to go live with 10 beds with 4 or 5 dedicated pathways. That's funded as part of a pilot with the HTAF funding, which was provided earlier this year. And then once we've got partway through this pilot, we're then going to look at seeing what we can do to establish it as an ongoing sustainable service.
Okay. We've got another question here from Tara. It says, have you considered inclusion of people who are neurodiverse and or have different learning skills or communication difficulties?
Yeah, absolutely, we have done, and it's inclusivity is one of those things which is really, really important, and we've been working closely with the Trust's team and the Director for Inclusion to make sure that we try to address these issues. Now, with any new service setting up, it's impossible to get it 100% right, and what we just aspire to. What we do find is that obviously neurodiversity covers a whole spectrum of challenges which people may have. The virtual ward environment is a fantastic opportunity for people who struggle with the busy, noisy ward environment, as many people do. We're also looking at the technology and ensuring that by working with
sorry, Iain, your microphone.
So we'll already have many support processes in place. So it's a case of working with those existing people or systems to enable that patient to access the virtual ward. So it's something which I think causes us to, when we're looking at technology, to keep the technology as simple as possible. And there's a dichotomy out there, if you look at the market, between consumer devices with your tech-enabled sporty geek who wants to know what their day-to-day variation is in their heart rate and this sort of maximum resolution of data, and the clinician who wants high-quality, reliable data, but not to overburden the patient with a complicated interface, which isn't going to provide that patient any benefit. So that's something, again, we're working closely with our technology provider, with Massimo, to make sure we get that balance right for our patients.
Okay, thank you very much. So we've got a question here from Sarah. It says, do you have any case studies of any clients with a learning disability who have been successfully supported to go home using this technology?
We do have a number of patients who have had severe learning disabilities and have gone home with it. Again, that's been done in partnership with their existing care team. We had a patient earlier in the summer who was paraplegic in a wheelchair, who had to have major laryngeal surgery, robotic ENT surgery was performed. That patient wanted to go home because their routine for achieving their daily personal care was too complicated for them to be able to do easily and in a way that they were comfortable with in the hospital. So the virtual ward enabled them to be back at home in their specially adapted environment, which they were familiar with and confident with, and therefore able to manage much better.
Thank you very much. And then we've got one from Paul. He says, excellent presentation. I wonder if you are aware of and in collaboration with other trusts embarking with virtual wards.
So yes, we work in, I don't know whether the questions come from the UK or outside, but the way how the virtual ward structure is designed in the UK is that we are supposed to function as a group within each integrated care system with clinical and managerial oversight from that integrated care system, ensuring it's within our region that we have weekly meetings where representatives from all of the virtual ward providers meet remotely and discuss any problems, challenges, incidents and events which have occurred. We then have clinical representatives from each of those virtual wards then meet with the regional team, which is, so that would cover the whole of East Anglia, in a clinical advisory group, which we do monthly. And then there are national conferences, which is also arranged. This is the virtual wards, if they're done properly, need to be done in partnership to avoid too much variation in services and pathways within a geographical area, because that causes confusion for patients and partner organisations.
Thank you very much. And this one's for you, Andy. It says, can Andy repeat what he said about winter beds last year, please?
So what I said last year was, so the virtual ward was launched in November 2022, but I've been at CUH now for 10 years, and every year we we open what's called a winter ward, which creates additional capacity for the hospital. So we normally open an extra 30 beds if we can. This year, the winter just gone was the first year that we didn't do that as an organisation. Now, what I would say is I can't say that that was all down to the virtual ward, but I'm pretty sure that there was quite a big impact on that because of the virtual ward, because it wasn't something we offered the year before in quite the same way.
Okay, thank you very much, Andy. So we've got another question here. Will the children's virtual ward include a neonatal service?
So the neonatal services already have patients who will be really well suited for the virtual ward, but they're not starting with the neonatal patients in the first instance. Although there was talk about the opportunities for certainly with the phototherapy and things like that, as they would be low risk patients to bring in. But no, the neonatal one is definitely there and is hugely valuable. The other thing to remember is with many neonatal services, they're already pre-existing sort of home ventilatory services and things set up. So in some ways, paediatrics is many, many years ahead of where we are with the adult services for certain aspects. But in terms of opening up a more generic virtual ward for wider ranging acute diagnoses, which are then patients are expected to recover from, that's where the paediatric virtual ward work. And that's where the gap in service of paediatric virtual wards really is. So does that answer the question?
Yeah.
Yes, we're going to be doing stuff with neonatal. The new paediatric virtual ward is not focusing on neonatal in the first instance. There are already services in place for neonatal patients, some of which could be considered to be very similar to virtual ward in their structure and function.
Thank you very much. And then we've got a question here from Patricia. She says, has there been instances where the technology provided inaccurate data?
I'm sorry, I've missed that last bit of the question, sorry.
Has there been instances where the technology provided inaccurate data?
So with any monitoring device, the reliability of the data that it generates is dependent upon how you're using that. And with any device, there is a range of inaccuracy. So we have occasionally had instances when the values haven't made clinical sense, but what we found is normally that's because of the way in which the device has been applied. So if you squeeze a pulse oximeter on too tightly, then you're not going to get an accurate reading because that skin isn't going to be perfused. But when we onboard the patients, we're very careful to make sure we teach them how to use the device correctly in order to minimize that. The same is true with inpatient, in-hospital devices. With my intensive care patients, occasionally I look at a number and think, well, that just doesn't make sense. Let's move it from one finger to the next. Let's allow the perfusion to improve there. So you're going to get that in any environment where you're monitoring, where you're relying upon a technological device to translate a biological signal into a digital format. So it does happen, but again, we teach patients how to minimize it, and then we work around it and we troubleshoot. Worst case scenario is one of the healthcare assistants will go out to the patients at home and then sit with them and make sure that technology is working properly in their hands.
Okay, thank you very much for that. And I'm going to have one more question because we are due to it will be 2 minutes. So I'm just going to pick through. Again, apologies if all questions haven't been answered. We will get them answered at a later stage, whether it's via email or something like that from the speakers. Let's pick one here. do you have specific virtual wards pathways, CRPD virtual ward, fertility virtual ward, etc.? And that's from Patricia.
So yes, we do. So essentially, there's two ways you can get to our virtual ward. There's one which, as described, we have a set pathway with. So, for example, with orthopedics, all of our knee replacement surgery patients, as part of their pathway, the moment they can mobilise and they're safe to discharge, they come straight onto the virtual ward and they stay for a couple of days just while we manage discharge. And we have a number of those with quite a few different services. For example, haematology, heart failure, frailty, oncology. We've got quite a few of those developed now. Ileostomy as well, reversal of ileostomies as well. We've got a pathway with. So that's kind of one way you can become a patient that gets to a virtual ward. That we've got that agreement with that service of what will happen to that patient when they come onto the virtual ward, what our team will do, what their team will do, and what the escalation is and what the expected length of stay is. But then the second way is, because we built such a good relationship now across the hospital with all the specialties, is we have this bit of a free-for-all system where any patient, any board round that's happening that day, if they see a patient that's suitable to be managed on the virtual ward, they'll literally just put in a referral order, and then we'll go out and go and see that patient and consent for them to come on. So two different pathways. And yes, we do have a lot of sort of specific pathways with individual services.
Yeah, thank you very much for that. And sorry, I'll just see, because Crystal has spammed the chat a bit. She's got one last question, which I'm just going to, this will be the last one again, guys. Do you bring patients back into hospital overnight if their remote monitoring drops out? So this will be the last question, guys.
I can answer that if you like. So when we're on the virtual ward in the hub, if we notice that the remote monitoring has dropped out, then we call the patient. It's not ideal, but we do explain that, you know, we have to be safe. We haven't had to bring anyone back into hospital because the remote monitoring is working, fortunately. But what we have found is that it might just be that the patient hasn't charged their mobile phone, so it's run out of battery, or that they've taken the device up while they're sleeping. So it's always the best option is just to call the patient just to make sure that they're safe, and then try to deal with it that way. But we haven't actually had to bring anyone in overnight, simply because the remote monitoring stopped working.
And okay, thank you very much for that, Gemma. That will be the end of the session today. So again, thank you for everyone for attending, and thank you for the speakers as well.
Thank you.
Thank you.
Okay.